Okay, hello. So should I take that as permission to go over 10 minutes, Mira? Just kidding. So yes, as Mira said, my name is Sandra, pronoun she, her, and I did my practicum with the Northern Health Authority's ethics team. So for those who may not know, Northern Health, one of many health authorities, but one of the 5 regional, 600,000 square kilometers, 26 communities, and 55 First Nations. So it's a very unique area of the North. And I did my practicum with Dr. Alonzo Prieto. She is the ethics team at Northern Health. And she is doing a project on moral distress in healthcare. And so as a part of that project, she asked me to do a literature review on ethical decision-making tools for workers in healthcare. And so today, I'm going to talk a little bit about the context of that lit review, some of the things that stood out for me, and then a hope or a possibility that I have for moving forward. And for those who may not know, because I didn't until I did one, a rapid review is a type of literature review that streamlines selected components of review processes while maintaining methodological rigor. I wrote it out very carefully. So starting in a good way, I do want to acknowledge that I live and did my practicum on the unceded territory of the Culminating, and that today we are on the unceded homelands of the Lekwungen and Wasanic Coast Salish peoples. So I hope today folks take a moment and reflect on what it means and how it feels to live and to thrive on land that is stolen. And yes, Mira did encourage us to position ourselves. So this is kind of where I sit on different intersections of power. I have here 2 pictures, my grandma Sally and my mom Joanne. These are the women who came before me, and they are who I carry with me every day and kind of make me part of make me who I am. And who I am is a settler and an expat, which is and isn't different than an immigrant, and I'm happy to talk on the break if people have questions about what that means. I'm cisgender and I'm queer, and I'm the eldest of 4 kids. All of these are little facts that are also describing power and my power relations that shape my work and thus shape what I even will be presenting today. So that is the lens that I come from. So moral distress in healthcare. So the definition that Esther and I use is feeling unable to practice personal or moral values and feeling emotional discomfort as a result. And that distress can build up over time. So it impacts individuals and it impacts the whole healthcare system. This is a public health issue. It may sound individual, but it is quite systemic. The numbers vary, but research does show that the frequency and the intensity of moral distress in healthcare is going up. So what that's resulting in is more clinical errors, less engagement at work, reduced patient safety, reduced quality of care, and more people are leaving their positions in healthcare, or they're leaving healthcare altogether, which isn't great, not ideal. And so what role do ethical decision makers have in moral distress, you may ask? There are 2 protective factors when it comes to moral distress. The research shows there's 2. I'm sure there's more, but there's 2 that I found in the research: strong ethical leadership and a positive ethical climate. So using ethical decision-making tools results in an improved ethical climate, and the ethical climate is shared norms at an organization, so the kinds of things that we agree are right or wrong. And so using ethical decision-making tools improves the ethical awareness of the folks that use them, and staff and leaders feel increasingly confident in their decisions when they're faced with ethical dilemmas. They standardize processes and improve transparency, so you have less staff that are doing decisions based off vibes, and instead it's this very standardized process. So I do want to ask online and in the room if there's anyone here who has ever used an ethical decision-making tool at work. If you could raise your hand. Yeah, that's what I expected. I can't see online, but I'm assuming which we should never do, but I'm doing it anyways, I'm assuming it was similar to in the room. So we have this massive variety of people here right now, right? We've got students, we've got professionals, we've got academics, and there were 4 hands that I saw, plus whoever was online. So I, as a social worker, I've been working in social work 10 years, and I only started using a specific ethical decision-making tool last year. So that's not ideal, again. So we'll come back to that, but I'm not surprised by the numbers. So as I said, I did a rapid review. So I do want to highlight a few steps. I promise I'm not going through every one of my steps, but I'm just going to highlight a few. So my research question, I used the population concept context framework. What ethical decision-making tools are available for healthcare workers and healthcare leaders experiencing ethical or moral challenges at work? Very straightforward. And not listing all the criteria for inclusion and exclusion, but I do want to highlight the 3 conditions that Esther and I agreed for a tool to be considered an ethical decision-making tool for our purposes. Action-orientated, structured, grounded in ethical principles. And that really helped me narrow down a lot of my results because I was starting to feel a little overwhelmed because I got 4,300 results that I had to screen, which was a lot, and ended up including 38 studies, which was 40 tools, and then in my cumulative report, of course, was more focused. There is a mismatch, you may notice, between the amount of studies and the amount of tools, because sometimes studies talk about more than one tool, and sometimes a tool is described in more than one study. But these are huge numbers. And I do want to reiterate, I was doing a rapid review, so I took 2 months. I didn't do every database under the sun. I barely included query literature. I had 2 months to do it. I was a single reviewer, and we had some fairly strict inclusion criteria. And that's how many I found. So there's clearly a ton of ethical decision-making tools out there. And another number I want to highlight is how few were evaluated. So most tools that I found were described or illustrated in a case study. 10% of 40 is 4. I had 4 tools that I found that were evaluated. Now, I'm sure there's more out there because, again, rapid review, I didn't find every tool in existence, but of the ones I found, 90% were only described. So we have this abundance of tools available. We have very few that are evaluated, so this isn't ideal for evidence-informed public health. And we had 4 people, that's actually 4 tools, 4 people. We had 4 people in this room, and however many online, which again I'm assuming, but not many, in this room in Zoom full of professionals, we had 4 people that are using these tools. So there is a major disconnect happening here, right? Wouldn't you guys agree? Nodding, yes. For everyone online, they're nodding. And so first of all, my first recommendation, obviously, we need more tools to be evaluated. We don't need any more. We don't need to reinvent the wheel. We just need to start evaluating the tools that are out there. My second recommendation is that we need to make better use of the tools that are out there. So if there are any bird watchers online or in the audience, I'm one, you may recognize the Merlin Bird ID app here. So it inspired an idea for me to increase the uptake of ethical decision-making tools. So in the Merlin ID app, there's this database with hundreds of birds, and then you answer a few questions. These are the 3 questions. And then it generates a little list of possible birds you've seen, usually about 6 or 7, sometimes more. So it helps narrow down what you may have seen. So what if we had an app, a database rather, of 40 or 50 or however many ethical decision-making tools, all of which of course have been evaluated and found feasible. And we have this app and online access so that staff and leaders in healthcare can answer like 2 to 4 questions. These are some examples. These are definitely not written in stone. Thank you. And that would generate a list of, say, 3 to 4 tools applicable for whatever situation that you're in, right? So I don't know if everyone can see that okay. I apologize if it's small, but I had to work with a screenshot. And so my thought was that it would improve accessibility, so these tools are easier to find and being all in one place. With the filtering questions, those screening questions, we're reducing that cognitive load. So in a dilemma, when you're already, it might be a crisis, hopefully not, but hopefully you have time, but either way, you're already frantically trying to think through your options, so reducing that cognitive load. And with an app, you can embed feedback And so we're going to have evaluation in real time, which leads to better informed practice, right? So this is a possibility that might be explored at Northern Health. And I do know that yesterday we were talking a little bit, some of the presentations, and I know, Joel, you're going to be talking about this too. Tech isn't always accessible, it's not always ideal, but because we're focusing more on workers and less so on clients, hopefully this would lead to more uptake, and it would be, I don't know, one option for folks, and maybe we can actually start using the millions of, hundreds, let's be accurate, hundreds of tools that are out there. So that was my time, and I just want to thank my supervisor, Dr. Alonso Prieto, my professor today, not today, well today, but this term was Dr. Amira Derbar, and all the professors, some of who are in the room that have been with me on this journey, and my husband Tyler, because he has supported me for so long so that I could be a master. You guys, I took 4 years and I'm finally here. Thank you.